Good morning, good afternoon, good evening, colleagues, wherever you are located. Welcome to our public health conversation series. My name is Dr. Folarami Ogunbowale from Division of Healthcare Management and Occupational Safety and Health, UN Secretariat, New York, from the public health section. So this morning we'll be talking about fakes, fads, and facts, debunking the top 10 myths about heart disease. You know, we've had a lot of misinformation, wrong information passing around about heart disease. Oh, if I'm drinking apple cider, can I prevent heart disease? If I'm eating a lot of garlic, does this prevent heart disease? Is heart disease only common in men or women? Or do I stand the risk of developing heart disease after menopause? Things like that. A lot of misinformation about heart disease going around. And if you go online, there are tons of information that you can see. If you open some of the social media platform, a lot of information. Everybody has become expert in the field. Everybody giving their own opinion. That is why we have actually thought on it, and we are bringing an expert who will be taking us through fakes, facts, and facts about top 10 myths about heart disease. This morning, I have the pleasure of introducing Dr. James Beckerman. He's a cardiologist and medical director of heart programs with the Providence Heart Institute in Portland, Oregon. Dr. James graduated from Harvard College and Harvard Medical School and completed his residency in cardiology. He completed his medical residency and cardiology fellowship at the Massachusetts General Hospital and Stanford University. So he is a passionate community health programmer, and Dr. Beckerman is also a medical director of Base Camp Prevention and Wellness, which provide educational program and fitness classes to thousands of people each year. He developed Play Smart Youth Heart Screening in 2012. This provided free screening to over 40,000 children. He also enjoyed coaching Heart to Start, a free 5K training program with nearly 3,000 participants. Dr. Beckerman is passionate about volunteering, which has brought him to different parts of the world, including Guatemala, Mexico, Russia, Nepal, Panama, Uganda, and has done a lot of work also in Nigeria and Kenya. This morning, he will be taking us through these topics. And by the way, he also enjoys playing, doing a chainsaw wood carving and playing flamenco guitar. So we'll hand over to him. He will first of all take us through some presentation. Then after his presentation, we will answer some questions. So if you have any question that you want to ask Dr. Beckerman, like I said, he's a cardiologist, so that you take home the truth and leave the fakes and the facts. So if you have any question in mind that has been bothering your heart about heart disease, drop it in the chat box. Then we'll be able to ask Dr. Beckerman at the end of his presentation. So, Doc, over to you. Thank you for joining us this morning. Thank you.
It
Over
is
to you.
my pleasure. Good morning, good afternoon, good night. It's great to see all of you out there, and I'm so thankful for the opportunity to get to present to you today. I just wanted to start by thanking all of you for what you do to keep our world a little safer and in more harmony. So today, we are going to be talking about heart disease, but I thought it would be interesting because no matter where you are in the world, all of us have some access to information on the internet. And that means that we also have access to misinformation or even disinformation. And when it comes to health, there's actually a lot of it out there. Some of it is provided by people who want to make money off of us. And some of it is provided by people who want to make money off of us and also, unfortunately, sell us products that can even harm us. So I thought that we would get into it today. Our story begins with this very interesting invention. This goes all the way back to 1796. So in the United States back then, there was this physician named Elijah Perkins who came up with this very interesting idea. He developed these two metal rods. You'll see one is made of iron, one is made of brass. And his idea was that if he touched these two rods to any part of a person's body, he could heal or cure that portion of the person's body. So I know this sounds a little bizarre in the world of modern healthcare and modern medicine, but people bought it. And as you might guess, some of them actually felt better when Dr. Perkins did this for them. So as a result, Dr. Perkins was able to sell a lot of these items, which were called tractors. They cost about $25 back then, which is about 500 US dollars today. So a lot of money. And they were sold everywhere, all over the United States, even into parts of Europe. And President George Washington, the United States' first president, even bought one. So this is perhaps where misinformation started, at least within the American healthcare system. Here is a beautiful depiction of Dr. Perkins working on somebody. You can see those metal tractors being applied to that person's face, and they look like they're in need of some help, and who knows if it actually served that purpose. But what purpose it did serve was a few years after Dr. Perkins' death, another physician named John Haygarth, who actually was instrumental in helping to address smallpox at the time. Dr. Haygarth had this idea. He said, what if instead of creating an iron or a brass metallic tractor, what if I created some out of wood? And same size, same shape. And I did an experiment where I randomized some people to the metal tractors and some people to the wooden tractors to see if there would be any impact on how the people did, if their symptoms improved. And that's exactly what he did. And as you might guess, based upon your current understanding of what this placebo effect idea is, some people actually felt better with the wooden tractors. So in the end, these completely useless interventions were equally completely useless, but also strangely somewhat useful for certain people. And this led this physician to publish this important book at the time called Of the Imagination as a Cause and as a Cure of Disorders of the Body. So when you think about the idea of a placebo effect or a sugar pill, or the idea that you can take some miracle vitamin and actually feel better, you can think about these metal and wooden tractors of the late 1700s. So here we are looking at a different period of time. You know, the word quack is often used to describe physicians or other healthcare providers that provide less than optimal services. The word quack actually comes from this word, quackzalver, which is a Dutch word, which actually describes an old-time physician or pharmacist of long ago who created salves or potions or creams to apply to the skin to help cure whatever abnormality lay beneath. But obviously they weren't really doing that. And so those people were called quackzalvers because they were people who created fakes. And so that's where our word comes from today, which I thought was pretty cool. Unfortunately, now we have a very different version of this type of misinformation. These are just some quick ads that I was able to find from the internet. You may have heard of raspberry ketones, red palm oil, and then we have my favorite green coffee bean extract with somebody lifting weights. And the idea is that all these products are supposed to be somewhat miraculous in some way and allow you to prevent heart disease or lose weight or be perfect without really having to eat healthy or exercise. So unfortunately, that's where we are. And the truth is we have not come a long way. Some people will remember these cigarette ads. The one on the left is from 1970, and the one on the right is from 1995. And I found it interesting that over that same 25-year period, cigarette makers were attempting, as they still do in various parts of the world, to appeal to people in our society that smoking brings with it beauty or wealth or independence, or even health, to be honest. And the reality is we just haven't come a long way, even despite our best efforts in combating misinformation and disinformation. And despite the fact that we're more skeptical than we've ever been before. But strangely, we're less skeptical when it comes to the promises of what different companies give in terms of improving our health. I love this old ad. I'm not sure what year this came from exactly, but this is the type of ad that you saw a lot in the 1920s in the United States, where you would have some form of product and you weren't even sure what it was. What is an aromatic invigorator? But apparently it's a cure for pretty much everything. You can see there it says dyspepsia, low spirits, heartburn, colitis, wind in the stomach, and even depending on the your interpretation of the appearance of these two gentlemen, even baldness. So these are the types of things we see. Unfortunately, even today, we are seeing misinformation when it comes to tried and true products as well. So I found these book covers talking about statins, which are a very commonly prescribed form of cholesterol medication. In fact, it may be one of the most prescribed medications in the world, and happens to also be one of the most studied medications in the world with respect to lowering the risk of heart disease, lowering the risk of heart attacks, lowering the risk of death in people who've had heart attacks already. So the fact that we see these types of book covers and misinformation about products that actually help us is also somewhat disheartening. For fun, I jumped into Chat GPT and thought to myself, what would an ad look like for a product that would prevent heart disease? And so I asked AI to create that for me, and I love what it came up with. You can see some form of tonic on the left side, and on the right side, some complex machine that you can imagine maybe, I don't know, has electrodes that you apply to your skin and help to prevent heart disease or something like that. The wonders of AI. But now let's get into it. Some myths about heart disease, specifically heart disease prevention. I see all kinds of patients in my practice, people who are younger, who are hoping to prevent heart disease, who might have risk factors, and then people who have already experienced heart events. And I've recognized that over the years that there are a lot of misconceptions out there, and sometimes those misconceptions can cause people to avoid getting care, and also can get them to be maybe a little bit less aggressive with the kind of care that they're seeking. And sometimes it leads to a lot of skepticism about whether the care is effective. So I thought I would break it down with a few of these so-called myths that I've seen in my practice over the years. And as I go, if you do have any questions or disagreements or anything, please feel free to drop them in the chat and I'll do my best to address them all. So one thing that comes up is the idea that a person is too young to think about heart disease. And I can understand why that would be. We all have a degree of denial in our lives. And, when you're a younger person, you feel great. The last thing on your mind maybe should be the idea of having a heart problem. But what we're talking about is a very slow progressive process. So here's a depiction of a heart. You can see the normal artery on the top, and you can see this plaque that starts to develop inside the wall of the artery. And as you can see, it starts to encroach into the opening of the artery, therefore obstructing blood flow. And interestingly, research studies done doing autopsies on young soldiers that had died in war found very early evidence of plaque in some of their blood vessels. So we're talking about very healthy young, typically men in their 20s or even late teens, who had very early forms of what we call atherosclerosis. So the fact that atherosclerosis starts developing when we're young suggests that if we intervene earlier, there's something that we can do about avoiding the endpoints of heart disease when we're older, things like heart attacks and strokes. The reality is that the risk factors that you have today can lead to coronary artery disease and problems like heart attacks tomorrow. Now, some of these are pretty commonly known about, things like high blood pressure or hypertension, having abnormal lipids or high cholesterol, diabetes, whether you have type 1 diabetes, which is the form that most often impacts younger people, or type 2 diabetes, which is an increasingly common adult onset diabetes that has come on in full force really in the past 25 years. Smoking or any nicotine use. A lot of people are transitioning to vaping as an alternative to smoking. And that unfortunately is also a risk factor. Someone just asked in the chat about secondhand smoke, and that absolutely can be a risk factor as well. As you might guess, it's a little bit harder to quantify because whereas it may be easier for somebody to say, I smoked 10 cigarettes a day for 25 years, secondhand smoke or even bad air pollution, like many cities around the world have, can absolutely be risk factors, not only for lung disease, but for heart disease as well. An unhealthy diet is a risk factor, and we'll get into what some of the healthier diets might be. A sedentary lifestyle, and you may have heard that sitting is the new smoking, and the idea that not only should you try to get a certain amount of exercise, intentional movement every day, but you should also try to avoid sitting all day. And a lot of people, depending on their work, might find themselves in a chair throughout most of the day. Sleep apnea is an important risk factor. HIV is something that a lot of people don't think about. Chronic kidney disease is an increasingly recognized risk factor, and also autoimmune disease. And I left off of this list obesity. And I'm so glad that some people have put that into the chat asking about high body mass index or a metabolic syndrome. And I I didn't include it specifically just because I wanted to touch on it in a little bit more detail. Obesity, we're recognizing, is this increasingly complex chronic medical issue. The fact that you've seen all this new data about these new weight loss medications called GLP-1 agonists that help to change the way that we digest food slightly and also the ways that our brains think about food, resulting in incredible amounts of weight loss that we really haven't seen in other medication classes, and also increasingly lowering the risk of other kinds of medical problems, specifically in my arena, in heart failure. And so a thing that has been controversial about obesity or being overweight over the years is the concept, is it possible to have a healthy form of obesity? And what I mean by that is if a person has obesity but does not have hypertension or diabetes or abnormal cholesterol, is their obesity still a risk factor for health problems down the line? And I think it's a really important question that people have been asking. And more, the data seems to be saying to us that while certainly if a person who is obese does not have those risk factors, they're in a better spot than if they did, it also appears that being at a healthier body weight does have health benefits, not only in the cardiac space, but in other spaces as well. So a second myth that I want to touch on is, well, heart disease runs in my family, so there's nothing that I can do to prevent it. And I've heard this multiple times. The idea that a person sort of gives themselves an excuse to not pursue healthy lifestyles because they feel doomed by their genetics. And I think that that's kind of a convenient approach sometimes that some of us take. I understand why it happens, but I really want to touch upon something called the 80% opportunity. So what this refers to is the idea that roughly 80% of heart disease can be prevented by how you eat and how you move and how you live. And so while, yeah, genetics matters, of course it matters, particularly if you have a family history of people developing heart disease at a very young age, or if you unfortunately have a family history in which people have died suddenly of presumably from heart disease at a younger age. Those are obviously very important situations that should cause a person to be more aggressive about testing, potentially screening, and definitely aggressive modification of risk factors. Somebody asks in the chat, can plaque be reversed with a healthy lifestyle? This is a really interesting question. So there have been anecdotes, and I use that word anecdote purposefully, of people who have adopted certain types of diets and have experienced kind of before and after, quote, miracle changes in their blood vessels, where plaque has truly been reversed. Um, but I will say that that hasn't been studied vigorously in a randomized placebo-controlled trial. And so, even though there do exist before and afters that are very impressive with diet, generally speaking, diet seems to lower risk of heart attacks and even death from heart disease, but the elimination of plaque is definitely a loftier goal that people are less likely to achieve. I appreciate all the questions coming in the chat. And what I'm going to do is I'm going to continue with the slides. And then after that, I'll be able to go through all those questions and address them. So off we go. So I wanted to comment a little bit on this 80% opportunity concept. And so if you have some free time and a good internet connection, I suggest that you check out that website down below. And obviously that's a big website to type out right now. And so if you were just to Google American Heart Association Prevent Calculator, you'll be able to estimate your own risk of heart disease. And what I love about this is you can input things like your age, your gender, information about risk factors that you know about, and then the calculator will give you a rough percentage likelihood of you having a cardiac issue over the next 10 years or so. And I think it's really useful because you can make little adjustments in various risk factors and see how they impact your total risk overall. And these are all risk factors that you can do something about, like your cholesterol or smoking or blood pressure, et cetera. So it's a fun thing to check out. You may remember this guy from cartoons of your childhood, definitely big for me. And this is an analogy that I use a lot with patients. Um, we hate to think about it, but gravity does exist. And what I mean by that is that at some point in our lives, we will hit the edge of that cliff and we will fall. And that's a hard thing for us to get our minds around. But the thing that is different for all of us is where that cliff is. There are some people, speaking of genetics, whose cliff might be very far away from where they are right now. Or unfortunately, there are some people whose cliff is much, much closer based upon genetics alone. But what we do have control over is how fast we move toward that edge of that cliff. And that's what these risk factors are all about. Addressing risk factors, having a healthier lifestyle, it slows you down as you try to approach that cliff. And in fact, in some cases, it can even back you up just a little bit. So I always think that this is a useful analogy to use with patients, and feel free to steal it. So another question that people ask about, or the myth about, is cholesterol. I don't need to have my cholesterol checked until I'm middle-aged. And I can once again understand why that's something that people might not want to think about. But the reality is that having abnormal cholesterol is a major risk factor for heart disease. The World Health Organization estimates it contributes to 50% of heart disease worldwide. People have over 2.5 times risk of developing heart disease if they have it. And if they also have hypertension, it balloons your risk to 18 times. If you can lower your cholesterol, it can be associated with a 30% or 1/3 reduction in your heart disease risk, regardless of where you're starting. So it makes sense that if your risk is higher, then the benefit from lowering your cholesterol is even greater. If you're a very low risk person, then it's fair to say that the actual benefit to you of lowering it is less. But over time, as your risk increases as you age, the benefit of lowering it increases. So start with lifestyle changes, and medications are definitely helpful if they're appropriate. Some people think, if I had high blood pressure, I'd feel it. I'd feel something. I'd get a headache. I just wouldn't feel right. I don't really need to monitor this. But we recognize for many years that high blood pressure is a silent killer. I remember when I was growing up, there were actually ads on TV talking about hypertension as a silent killer. It was a public health service, I suppose. And I found this article from 1977 that I think coined that phrase. So I thought that that was pretty cool that this is something that's over 50 years old, or about 50 years old. I also found these ads. These are, I believe, from the 1930s or 40s. And the idea here, these life insurance companies would put out ads, trying to encourage people to address their high blood pressure. Because if you think about it, if you're a life insurance company, you want your people to live for a very, very long time, so they keep paying those premiums. So these are obviously some stereotypes of someone who might have hypertension, which in the cases of these ads is somebody that is male and white. Obviously, hypertension impacts everybody. The goals of combating hypertension: lower is better. And depending where you are in the world, the guidelines on lowering blood pressure might be a little different. Right now in the United States, our guidelines recently changed from 140/90 to 130/80. So lower is definitely better. And it actually turns out that even among people with normal blood pressure, a lower blood pressure is still better. If your blood pressure is 100/60, that's better than 120/80. When you think about it, think about a healthy 15-year-old. What's their blood pressure? It's not going to be 135/86 or something like that. That might be, quote, permissible in an older adult. It's going to be something more like 105/65. And I think that those are good goals actually for the rest of us. Of course, you want to be able to tolerate medication, not have side effects, all that kind of stuff. But generally speaking, lower is better. Next myth: it's okay to have high blood pressure when you're older. And back in the day, lots of doctors said, yeah, it's acceptable if my older patient has high blood pressure because, I don't want to cause side effects, which is always a valid reason to be careful about blood pressure medication use. But this question, is it okay to have higher blood pressure when you're older? Well, this research study that was published over 30 years ago actually addressed this question, where a significant number of people, almost 5,000 people, more than half of whom were women, were randomized to a placebo versus different blood pressure medications, followed for nearly 5 years. And they found that when they controlled blood pressure well in these older people, it was associated with a 36% reduction in strokes, 27% reduction in heart attacks, and a 13% reduction in death over a 5-year period. So this really hammered the idea that a healthier blood pressure in older people as well as younger people is a good thing. And so we find ourselves being more and more aggressive, but also very cautious in terms of the medications that we give and the side effects they can potentially cause. So that's always an important consideration. So diabetes, a really important risk factor for heart disease. And some people are optimistic that if they treat their diabetes, then it's no longer a risk factor for heart disease. And I just wanted to touch on that including these hilarious ads from the 1960s in which sugar companies, you can see brought to you by Sugar Information at the bottom of the screen, they put out ads in newspapers suggesting that if you consume sugar before a meal, you'll be less hungry and have more energy. And I love the idea that it's a diet hint is to have a soft drink before your main meal, or just nibble on a cookie about an hour before lunch. So at least we won't be seeing these types of ads today. Um, Diabetes, unfortunately, is a heart attack equivalent. So tighter sugar control, it does lower your risk of diabetes-related complications, particularly kidney, nerves, and eye complications. But managing diabetes well has a limited impact on your larger blood vessels, like the ones in your heart. So unfortunately, if you have diabetes, even if you're managing your diabetes well, you still have to be super aggressive about risk factors in general. And so consider statins to lower cholesterol, even if you have normal cholesterol. And you may have heard of this newer class of medications called SGLT2 inhibitors. These are medications that are prescribed for diabetes, but also seem to help with kidneys and heart disease too. So they're really an interesting and exciting class of medications that are relatively new to the market. There's still a bunch of smokers out there, I'm sorry to say, and a lot of people believe that if they've already been smoking for a long time, then they can't reduce their risk. What's the point? That's something I've heard quite a bit. This is a classic ad in which Lucky Strike tried to basically communicate this falsehood that tons of physicians were saying that this was the preferred smoking brand, that they were less irritating to the throat. And if you go on your favorite search engine, you can find tons of ads like this from the 1960s. I think they're just amazing that they were published and are there to entertain us now. But unfortunately, 1.1 billion people still smoke. It's incredible for me to imagine that. In the place where I live, smoking is quite uncommon, but to think how common it is throughout the world, it's quite amazing. 80% of smokers live in lower middle income countries. And when we think of this global reduction in smoking, it's generally limited to the global north. In fact, during a 20-year period in sub-Saharan Africa, tobacco consumption increased by over 50%. Thankfully, tobacco advertising is now banned over most of Africa. We see in the United States that certain ethnic groups tend to have different prevalences of smoking, and some of that may be based upon access to healthcare. So still a huge problem that we need to address. And unfortunately, the tobacco companies aren't helping us. And we can still find in certain venues these types of ads, which tend to target particular populations, which I think is unfortunate. Some really cool statistics. After quitting smoking, within 12 hours, the carbon monoxide level in your blood returns to normal. Within months, your breathing improves. Within a year, your risk of heart disease is about half that of a smoker's. Within 5 years, your stroke risk is back to a normal level. Within 10 years, your risk of lung cancer and all these other cancers goes down considerably. And even though you got to put in your time, after 15 years, your risk of heart disease is like that of a non-smoker's. So it is absolutely still worth it to try to quit. And that's definitely the message we should be giving our patients. I found this statistic pretty cool. If you think of what age you're at, how many years of life expectancy you might expect to gain by quitting smoking. And so if you're 30, 10 years. And even if you're 60, 3 years of life expectancy. So there's no time that it's too late. I think that it's also important to realize that life expectancy, while definitely an important endpoint, it's not the only endpoint. Quality of life. things like strokes, chronic lung disease, things that a lot of smokers unfortunately will get if they stick with it. We can really reduce the risk of those if we quit smoking earlier. This is always an interesting topic. A myth. You can lower your risk of heart disease with all those vitamins and supplements that I showed the ads about at the beginning. Raspberry ketones, coffee bean extract. People joke that Americans have the most expensive urine in the world because of all the vitamins that we consume. Because what happens is those vitamins are generally not needed by your body and end up going into the toilet. So the question is it worth trying any supplements at all? And I think it's an important message as a healthcare provider to not be anti-supplement, but just to be pro-research and pro-data. And so if the data shows that something is useful, I'm absolutely all for it. So there are a few supplements where the data suggests that there could be some role. Coenzyme Q10, fish oil, particularly in people who have very high triglyceride levels, red yeast rice for cholesterol lowering, and also plant sterols for cholesterol lowering. But the list of supplements that don't have great evidence is much longer. A lot of the multivitamins that you see out there, things that claim to be antioxidants, folic acid if you're not a pregnant woman, vitamin E, D, niacin, beta carotene, and anything that is sold by a healthcare provider. If you're in a doctor's office and they're selling vitamins, I don't know. I would be an automatic skeptic in that case. I thought that this was a really interesting research study. So what they did was they found people with high cholesterol, and this was just a 30-day study. And they found that if they gave rosuvastatin, which is one of the statin medications, it lowered their LDL cholesterol by almost 40%. And that was a pretty low dose of this medication. And then they looked at a placebo. They looked at fish oil, cinnamon, garlic, which a lot of people like to take, turmeric, plant sterols, and yet red yeast rice. And the big findings from this study were that garlic actually increased cholesterol, and that plant sterols and red yeast rice both lowered cholesterol. So if you are looking for something to lower your cholesterol, it's not going to lower it by a ton, maybe 5%, but plant sterols and red yeast rice are definitely reasonable options to consider. So big question, the best diet for preventing heart disease. Drum roll, please. It's more complicated than that because it is very hard to study diet. If I asked you, what did you eat for lunch last Thursday? I bet very few people on the call could come up with that, because when we study diet, oftentimes we're asking people to recall what they eat. You may have heard of the concept of a food frequency questionnaire. So you got this questionnaire and you're supposed to share how many times a week do you have nuts, or when is the last time that you had processed meat? And as you might guess, people forget. And also, when you're there doing the research study, maybe you remember a little bit more selectively and more optimistically than the reality would suggest. So observational studies of human diet and health outcomes are very challenging. And randomized trials, great idea, but they're very hard to do. If we decided for fun to randomize everybody on this call today, half of you are going to become vegans for the next 5 years, and half of you will eat a carnivore diet for the next 5 years. How many of us would actually stick to it, or would be lost to follow-up? So when you hear about the best diet or the data for diets, be skeptical. Wonder, how did they get that data? What kind of studies did they do? There have been only 4 randomized trials of the Mediterranean diet for primary prevention, but the good news is within a relatively small period of time, 2 to 7 years, we see over a third reduction in heart attack and stroke. So Mediterranean diet, definitely great for primary prevention, which means you don't have heart disease already. Similarly, for secondary prevention, in people who had a heart attack, a Mediterranean diet had a very impressive reduction in death and cancer. So right now, the best data is for a Mediterranean diet. That isn't to say it's the best diet. It just means that we have the best data for it. And finally, what I want to touch as our final myth is that heart disease is a man's problem. And I wanted to share 10 facts from the Go Red for Women movement, which is an educational and awareness movement that's been around for several decades, which I think has been really useful around the world in helping people to realize that heart disease is a people problem, not a man's problem. So an important fact is that heart disease kills more women than all forms of cancer combined. But fewer than half of women realize that heart disease is their greatest health threat. Among women 20 years and older, almost half are living with some form of cardiovascular disease. Heart disease is the #1 killer of new moms and accounts for over 1/3 of maternal deaths throughout the world. And Black women have some of the highest maternal mortality rates. Overall, 10 to 20% of women will have a health issue during pregnancy, a cardiovascular health issue like high blood pressure or preeclampsia or gestational diabetes. And having one of these risk factors during a pregnancy increases your risk of developing heart disease throughout your life. So these people need to be monitored and screened and checked and have good follow-up. Going through menopause does not cause heart disease, but it does mark a point in midlife when risk factors accelerate, meaning that your risk starts to go up considerably. So it's really important as somebody is focusing on menopause to also focus on their heart disease risk factors. Most cardiac and stroke events can be prevented through education and lifestyle changes, moving more, eating smart, and managing blood pressure, what we called the 80% opportunity earlier. Half of high blood pressure deaths are in women, and out of all women, over half of Black women have hypertension. So an incredibly large group of people that needs to be screened and needs close attention and aggressive care to lower that risk of developing heart problems later in life. While there are an estimated 4.1 million female stroke survivors living today, that's in the United States, over half of total stroke deaths are in women. And it may be that women are less likely to recognize stroke and seek medical attention, and unfortunately, may be less likely to have more aggressive medical care, even if they are brought to attention. To that point, women are often less likely to receive bystander CPR because rescuers are fearing accusations of inappropriate touching or assault or injuring the victim. And so this is just another example of how women may be getting a level of care, so to speak, that's below our standard of care. And finally, it's really important to point out that fewer than half of participants in clinical cardiovascular trials are women. So much of the data that we have about how to treat or prevent heart disease is related primarily to men. And that's obviously unfortunate that we have to generalize those results to women. So it's very encouraging that in recent years, we are seeing more and more women, thankfully, being involved in clinical trials. And there are requirements about improving diversity of all types in clinical trials. So I thought I'd finish with this just kind of funny slide. So when I completed medical school, I took the Hippocratic Oath, which begins with this statement, and it mentions Asclepius. And so you may have in your mind that the symbol of medicine is a snake going around a staff or a sword. But it turns out that most of us actually think of this image instead, which you'll see is two snakes. And that's called a caduceus, which is a slightly different image than the image of the Asclepius. And the reason why I think this is funny is because the caduceus was an image, it was a misinformation image that was due to a mistake when the U.S. Army Medical Corps adopted this symbol in 1902, and it became a ubiquitous sign of healing, which is fine. But the actual image itself represents Mercury, or Hermes, who was the god of financial gain, commerce, thieves, and trickery. So no matter what we do, no matter how hard we try, we can't seem to get away from this idea of misinformation. So I'll leave you with this final image. This is something that my kids showed me that they saw on TikTok, which is a relatively new thing, that if you put duct tape over your mouth while you sleep, you will snore less. I don't know if they're trying to send me a message, but I also think that if you put duct tape over your mouth when you sleep, you might breathe less too. So I don't recommend it. Thank you, everybody, so much. It's been an honor to get to share with you today, and connect with me by LinkedIn, and I would love to get to know everybody involved here today. It looks like we have a bunch of awesome questions, which in our
Thank you
remaining
so
time,
much,
we'll go through.
Dr. James. We appreciate you have given us a lot of information, and you have actually debunked the fakes, and then you've given us the facts. Thank you so much for this. I will quickly go over some of the questions that we have in the chat, and we'll answer as many as possible as time permits, because I think we have roughly about 10 more minutes before we wrap up. So one of the questions asked here is that, please, could you comment on the current practice of initiating lipid-lowering medication for lowering LDL cholesterol based on cardiovascular risk assessment?
It's a great question.
Despite some studies showing no benefit in patients without any cardiovascular disease.
So here's what we know about cholesterol-lowering medications, and specifically we're talking about statins, because this is the medication class that has by far been shown to have the greatest potential benefit. So generally speaking, for primary prevention, we're talking about people who have not had a diagnosis of heart disease. The current recommendation in the United States is to do a risk assessment. And so I shared with you the PREVENT calculator, and there's also one called the ASCVD risk score. And these are things that you can Google and look up. And if somebody has a risk of greater than 7.5% of having a heart issue over the next 10 years, that is a signal to initiate some lipid lowering strategy. That might be lifestyle in some people, and it also might be medication in some people. And I think that the important point here is that for primary prevention, statins are far less likely to have a mortality benefit, but they still may have a morbidity benefit in the form of reducing heart attacks and strokes. And a very important point here is the difference between what we call relative and absolute risk. Meaning, if I lower your risk by a third, that sounds great. But if your risk was only 3%, I've only lowered it to 2%. Which is obviously just a drop of 1%, which is not very significant, frankly, and for a lot of people would not be worth it. So I think that when we communicate about risk reduction, especially when it comes to taking medications, we have to acknowledge that your benefit from a particular interventional strategy is based upon where you're starting in the first point in terms of your overall risk.
Okay. Thank you so much. Then the next question is this. You mentioned something about calculating our risk using the cardiovascular risk calculator from the American Heart Association. So somebody is asking, is this valid in Africans and other race, despite not having that risk listed in the calculator? What can be the alternative? Something like that.
Yeah, no, I'm glad that this was asked. I think that in particular, the PREVENT calculator that I shared, it has much better validity when it comes to assessing risk among different ethnicities. The original form of the ASCVD risk score was less reliable, frankly, when it came to looking at different populations. But over time, they did refine it multiple times. And so with all of these risk calculators, you got to take them with a grain of salt. they're not perfect, and we shouldn't hang our hats on them and say that they're the absolute truth. But I think that what you see is that they help to tell a story about a person's risk. And if you take a minute and do your own risk calculator, and you find, oh, what if I lowered my blood pressure from 150 to 130? What would happen? You start to see, oh, these small changes that I can make in my lifestyle will have ultimately a big impact on my future risk.
Okay, thank you so much. The next question is, once a person starts taking cholesterol-lowering medication, will he or she eventually stop taking it, or they have to take it for the rest of their life?
Boy, I get asked this question all the time. And the way that I respond to it is I say, well, if you've been wearing a seatbelt for the past 10 years, does that mean that you need to keep wearing it for the rest of your life? People don't like it when I say that because the message is that risk reduction is an ongoing thing, right? If you exercise a lot when you were in your 20s, that doesn't mean that you don't have to exercise when you're in your 50s. And so interventions like statins, like blood pressure medications, I wish that they were cures, and I wish that they were irreversible ways to lower risk, but they're not. If we stop taking them, our risk starts to creep up. Something that you'll start reading about more and more over the next 10 years is gene editing therapies. There's actually a company out of Boston right now that is looking at a way to edit your genes so that your LDL cholesterol will permanently plummet, therefore, hopefully resulting in a one-time treatment that will lower your risk forever. So it's in the future, but not yet today.
Okay. Are there any true miracle foods?
No. I wish there were, because I would eat them or drink them, but there aren't. And, you know, all the miracle foods tend to have something in common. They are not processed, they are natural, and they don't have artificial additives, right? So whatever berry or ancient grain you're thinking of, those foods are good for you, but unfortunately, there are no miracles out there. I wish.
Okay, thank you. The next one is anything regarding fasting diet for weight loss and cardiovascular risk mitigation?
Yeah, great question. So we've seen a lot about intermittent fasting over the past few years, and there have been some research studies looking at it, and I hate to say they have not been particularly encouraging. So intermittent fasting refers to the idea that you will only eat for a certain period of time throughout the day. For some people, it might be from 10 a.m. to 6 p.m. And so no food outside those hours, or even doing a day of fasting intermittently. And those strategies do not seem to be superior to just kind of more normal or casual approaches to watching what one eats and limiting calories overall. So it's not a magic pill, unfortunately. That's not to say that it would be harmful to you, but um, there's a gimmick to it, right? And if you can't imagine yourself doing this thing 3 years from now, don't start doing it today.
Okay. The next one is if you are physically fit or thin, maybe you are not on the, you don't have so much weight. Are you immune to heart disease?
Yeah, it's a great question. I wish that that was true. We've all heard stories of people who are athletic who experience heart disease, and it seems, counterintuitive. How's this possible? While exercise is possibly the most important thing that a person can do to lower their risk of heart disease, cancer, arthritis, dementia, any chronic illness, it's not perfect. And if you remember my cartoon of Wile E. Coyote falling off the cliff, exercise may slow you down as you approach your cliff or even help you run backwards a little bit, but we're all going to hit it at some point, and all of us are unfortunately going to develop some kind of chronic medical problem as we age.
Okay, thank you. Next question is this. Considering type 1 diabetics diagnosed earlier in life, say between age 5 to 10, what would be your thought on cholesterol lowering method? They are children. Pushing for dietary watch is tough. After how many years do we start to worry? When does one start follow up on their cholesterol values?
It's a great question. While I'm not a pediatrician, my general approach would be that at least until age 18 during the childhood years, to be particularly aggressive about diet, obviously, exercise, maintaining the healthiest body weight possible. And then probably at high school age, teenage years, start checking cholesterol. And if cholesterol is significantly elevated, consideration of cholesterol medication probably in young adulthood. Because I'm not a pediatrician, I'm less comfortable commenting on the appropriateness of statin medications in a teenager or younger, just because I'm less familiar with that data myself. But obviously, very important questions to ask.
Okay. Then the next one is can you just what is optimal exercise regimen?
Yeah, I get asked this all the time. So I share with them a phrase that one of my friends and colleagues once came up with: some is good, more is better, everything counts. And so the reality is, what is sustainable, meaningful, fun, possible for me as a person who exercises every day is going to be different than what it is for you, right? We're different people. We live in different places. We have different access to the outdoors, to leisure, to sports. And so it's going to be a different answer for everybody. Right now, the American Heart Association recommends that people try to achieve 150 minutes of low moderate intensity exercise per week, or something like 75 minutes of strenuous exercise per week. I find those recommendations always a little bit hard because I'm not that good at doing math. 150 divided by 7 days in the week. At the end of the day, I think that if you can try to be intentionally active for 30 minutes a day, and that could be divided up. It could be a 10-minute walk after your meals. It could be doing some actual exercise after you finish your workday or before it starts or in the middle of it. And throughout the day, doing your best to be just generally more active. So if you work at a desk, getting up, moving around, doing your best if you drive to work to park your car not at the closest place to where the front door is. If you're able to walk to work, consider it. So for everybody, it's going to be different, but some combination of aerobic exercise and some kind of resistance exercise, I think, is the key to having the best exercise prescription.
Okay, I know some of our audience will be waiting to hear this one. Is red wine good for you from a cardiologist perspective?
Oh man, I wish. So years ago, there were some observational studies that seemed to suggest that if people consumed small but regular amounts of red wine, there seemed to be a signal towards a reduction in cardiovascular risk. And some of this data was culled from looking at populations throughout the world who consume what we call the Mediterranean diet, which does tend to include some red wine at times for some people. So we've evolved a little bit in our thinking, unfortunately, for those who enjoy red wine, in that it seems that we've learned that any amount of alcohol seems to increase our risk of health problems. And the World Health Organization recently published a report on that. And part of the reason for that is because we often don't recognize, when you think of the health harms, of alcohol, you often think of liver disease. But one thing you often don't think about is cancer. And it turns out that any use of alcohol increases risk of cancer, particularly in women. The incidence of breast cancer and uterine cancer goes up substantially in women who consume, honestly, any amount of alcohol, and especially significant amounts. So while red wine might be delicious to some people, it unfortunately is not a health intervention at this time. Sorry.
Thank you for this for answering these questions. I mean, you clear most of the doubts now. Then my final question to you will be this: is there a relationship between endurance exercise training and increased cardiovascular risk? Because some people have the opinion that if you are doing like all this rigorous training, you have increased risk of having like a cardiovascular risk, because even some people may say you may even develop heart attack. So is there a relationship? Yeah.
Great question. So overall, people who participate in high volume of exercise have better health outcomes than people who don't. So that's just an important point. In the big picture, it's a benefit. However, if you dig in, you can notice two trends that we tend to see in people who do very high volumes of exercise. I'm talking multiple marathons, people who cycle, 200 miles a week, that kind of exercise, different than the casual exerciser or the weekend warrior. So in those people, we start to see an increased risk of an abnormal heart rhythm called atrial fibrillation. This is a heart rhythm problem that impacts millions of people increasingly as we age. But it seems that in high endurance athletes, we see an increased risk of it. So that's one thing. Another thing that we can see is that people who do a lot of exercise tend to have a bit more calcium in the blood vessels around their heart. And calcium is a sign of plaque. And so the question is the exercise causing more plaque, or is it causing plaque without calcium to develop calcium? So there's still controversy and debate around that. But the fact is that overall, endurance athletes are less likely to develop heart attacks and strokes than non-athletes. So I think that if you enjoy doing lots of activity, you should still enjoy doing it. It is a fair point and true to say that we are at a very small increased level of risk while we are exercising compared to when we're at rest. But that very small increase that is transient does not exceed the overall risk reduction that being an exerciser has. So keep exercising, please.
Okay. We are exactly 1 hour, 30 minutes, but I'm still going to ask this another question before we go. Bear with us. And the question is this. I think it should be one of our clinicians that has this question. If you see a patient in the clinic and they don't want to take antihypertensive, anti-lipid medication, they just want to do like some kind of home remedies, what would be your advice to such patient here?
Yeah, this is something that I see a lot. Well, one of the things that I do is when somebody says that I want to manage this with just lifestyle, I just want to do it on my own, instead of kind of shrugging my shoulders or saying good luck, I really try to engage them in a conversation about what it is specifically that they're going to do. And I treat their approach to lifestyle medicine as a prescription. And I'll say, okay, I can see why you might want to choose to do that. Let's dig into what exactly you are going to do. What is the intervention that you're going to do? And try to get them to be very specific. Because one thing we know about making behavioral change is if you approach it generally, I want to be more active this year, you're less likely to actually succeed. But if you say, 3 times a week on Mondays, Tuesdays, and Thursdays, I am going to commit to spending 30 minutes before work going on a walk throughout my neighborhood. All of a sudden, you have a very smart approach to behavior change. And so if somebody says that that's something they want to do, I wait for them to share with me, how are you going to exercise? What are you going to eat differently? And dig into that strategy with them. And then I can come back and share, well, yeah, that's great that you want to cut out ice cream. But maybe we also want to stop putting salt on our food and, try to push the conversation forward.
Okay. Thank you so much, Dr. James, for this wonderful presentation. I mean, you have really taught us so many new things and debunked some of the myths today. Thank you so much for this. And some of our colleagues, they are asking if we are going to share this presentation. This presentation is recorded, and if you want to watch them again, we will definitely share the link with you, or you can go on HR Portal where we normally host most of our presentation. You can always go there and rewatch the presentation, including the question and answer session. And thank you so much. I mean, definitely, James, we're definitely going to bring you back to come and talk more to us
I'd
on
love it.
something that has to do with art. We'll be getting to you on this very soon. So thank you so much for your time, everyone. Wherever you are, good evening, good night, and good morning. Thank you so much. We appreciate Dr. James for his presence and everyone participation in this presentation. Thank you so much and have a wonderful one. Bye-bye.
Thanks, everybody.